I'm Dr. Carolyn Majcher, a professor and the director of residency programs at the Oklahoma College of Optometry, and we're now going to switch gears and discuss the prognostic utility of multimodal imaging in diabetic retinopathy. And as I share this case with you, what I really want to highlight are the high-risk imaging features that are predictive of progression and worse visual outcomes post-treatment. So this is an asymptomatic 41-year-old male who's coming in for his routine diabetes examination. He's had type 2 diabetes for about 20 years, and unfortunately, it's very poorly controlled with a most recent hemoglobin A1C of 14%. And in addition to his diabetes, he also has other vasculopathic risk factors such as hypertension, high cholesterol, and his in-office blood pressure reading is elevated at 145/90. His best-corrected visual acuity is reduced more so in the right to 20/30 plus 2, and then the left eye visual acuity is good at 20/20 minus 1. And aside from that moderately high blood pressure reading, his external examination or entrance testing, as well as his anterior segment slit lamp examination, are unremarkable. Here's the ultra-wide field color fundus photography of the right eye that was taken using the Colaris camera. And this ultra-wide field photograph extends 200 degrees in horizontal diameter. And what we can see in this patient's right eye is severe intraretinal hemorrhaging, both blot and flame-shaped. There's no gross evidence of proliferation, such as neovascularization or vitreous or preretinal hemorrhage, but certainly the severity of the background retinopathy lesions would warrant further investigation and which should raise high suspicion for neovascularization being present. It's important to note here that the intraretinal hemorrhaging extends out into the periphery, especially in the temporal fundus, and arguably there's more hemorrhaging out in the periphery than within the posterior pole. And so this is the first high-risk feature I want to discuss, since research has shown that eyes with predominantly peripheral diabetic retinopathy, where the majority of the lesions are outside that standard 7-field ETDRS area, are at greater risk of progression. And this one study found that there was nearly a 5-fold increased risk to progression to proliferative retinopathy in individuals that had this predominantly peripheral presentation. However, the drcr.net protocol AA results were somewhat conflicting in that they did not find prognostic significance in the color fundus photography findings, but they did find on peripheral fluorescein angiography that was prognostic for future development and progression of diabetic retinopathy. So I think the take home is the more peripheral presentation, the more peripheral lesions, regardless of the imaging modality, there's probably an increased risk for progression to proliferation over time. And now let's loop back to our patient's case. I want to point out another telling, more advanced feature of diabetic retinopathy that we can see very nicely here on this ultra-wide field imaging, which is this peripheral vascular sheathing, which is suggestive of widespread peripheral ischemia and retinal non-perfusion. So we're going to expect as we move into our OCT angiography that there's going to be a lot of mid-peripheral peripheral non-perfusion present. Here's a magnified view of the posterior pole, where we can visualize some ERMA, especially in the superior temporal arcade, some venous beading and venous loop here, inferior nasal, as well as many cotton wool spots, which is another sort of telltale sign of massive retinal non-perfusion that we're expecting to see on OCT angiography. And here it is, the 14 by 14 millimeter montage OCT angiography, and we're looking at the superficial capillary plexus. You see there's extensive non-perfusion outside the arcades. And we know the greater the degree of retinal non-perfusion, the greater the risk of progression, right? Because there's more VEGF release, and VEGF then fuels neovascular growth. There's a vascular lesion in the superior temporal aspect of the fundus that's suspicious for neovascularization elsewhere based on its size and morphologic kind of C-band looking pattern. So it's important that we investigate this further to say, is this ERMA or is this NVE, which would be suggestive of proliferative diabetic retinopathy? So I used the slice navigator to go through this area of suspicious vasculature, and we can see that it is indeed intraretinal. So this is ERMA and very severe non-proliferative diabetic retinopathy. This is further confirmed by the lesion not being present on our vitreoretinal interface, which is designed to highlight proliferative retinopathy. So I think that our patient's right eye here is diagnosed in terms of the classification of retinopathy as having very severe non-proliferative diabetic retinopathy. If we go back and compare the current montage OCT angiography to that of 15 months prior, we can see that the retinal non-perfusion has been significantly progressing, especially in the temporal aspect of the fundus. Macular cube OCT reveals some non-center involved diabetic macular edema. There's a cotton wool spot causing a focal area of thickening. But then I also want to point out on these higher resolution scans some specific high-risk biomarkers associated with the worst visual prognosis. And the first one here is the central photoreceptor ellipsoid zone loss, which is likely contributing to this patient's 20/30 best corrected vision, even though the center of the macula has no edema present. The second structural OCT feature of note is this focal interretinal atrophy within the temporal aspect of the macula, which corresponds on OCT angiography to non-perfusion of both the superficial and the deep capillary plexus. And then lastly, another OCT biomarker present here is disruption or disorganization of the inner retinal layers, which corresponds again to non-perfusion on OCT angiography. Within the superior nasal aspect of the fovea here in the right eye, there's notable thinning of this ganglion cell layer in this region, along with the focal area of hyperreflectivity. And this corresponds to a sort of focal area of dropout or superior extension of the fovea-vascular zone, which corresponds to macular ischemia and likely this patient's 20/30 vision. And so I think this represents both past as well as acute interretinal infarction, the more acute infarction being this hyperreflective area, and the more chronic infarction being this area of atrophy or thinning. Looking now at the patient's left eye, we have the color fundus photography as well as the montage OCT angiography. This is a very similar presentation to the patient's right eye, where we have extensive intraretinal hemorrhaging as well as cotton wool spots. And on the OCT angiography, we have this mid-peripheral non-perfusion, which is rather extensive as well. But what's different and present in the left eye that wasn't in the right is neovascularization on the disc. And we can really highlight that using this 4.5 millimeter OCT angiography of the optic nerve head, as well as taking a cross-section through that neovascular tissue and looking at the B-scan overlay. So we have this hyperreflective tissue, which has red overlay on top of it, indicating active blood flow, and it's actually attached to the posterior hyaloid, so indicative of active neovascularization of the disc. And keep in mind that this patient's visual acuity was 20/20, so we can have proliferative diabetic retinopathy in an asymptomatic patient with 20/20 vision. Here, looking at the patient's left eye macular cube, we can see there's non-center involved diabetic macular edema, somewhat similar in presentation to the right eye. We have a cotton wool spot, which on structural OCT is signified by this hyperreflective thickening of the nerve fiber layer, and on OCT angiography corresponds to a permanent footprint of superficial capillary plexus non-perfusion that will be there even after the cotton wool spot resolves. There's also some minor photoreceptor ellipsoid zone loss here in the temporal aspect of the fovea. We also have some interretinal atrophy present, which is this little divot and atrophy of the interretinal layers in the left eye, as well as a ripple lesion, which is, the ripple stands for retinal ischemic perivascular lesion. And it literally looks like a ripple in the retina where we have this wave in the outer plexiform layer. And this is due to atrophy of the middle retina or inner nuclear layer highlighted in orange here. When we have that area of atrophy, it is represented on OCT angiography as a focal area of deep capillary plexus loss. So our assessment for this patient was very severe non-proliferative retinopathy with non-center involved diabetic macular edema and some macular ischemia in the right eye. And then for the left eye, we had proliferative retinopathy with non-center involved diabetic macular edema. We referred this patient to a retina specialist, but unfortunately he was lost to follow-up and returned to optometry 6 months later. You can see on the 6-month follow-up here, looking at the right eye, the patient developed new neovascularization on the disc, which isn't surprising, given all the high-risk biomarkers for progression that were present on the initial examination, along with that hemoglobin A1C of 14%. Here in the 6-month follow-up of the left eye, we can see there's worsening neovascularization of the disc, as well as worsening vessel ischemia and sclerosis, suggestive of this mounting and progressive retinal non-perfusion that's occurring. At 2 years follow-up of the right eye, he finally got his PRP in there, but we developed a pre-retinal hemorrhage. And then at 3 years, his visual acuity decreased to 20/50, likely due to some significant retinal non-perfusion. Here's the Zeiss Forum macular thickness analysis that allows for simultaneous viewing of 3 macular cube scans. And we can see at the 3-year follow-up, the macular edema has significantly improved compared to some of our baseline scans. However, the vision is decreased to 20/50, and that's likely a result of macular ischemia, as well as some interretinal atrophy, which we visualized earlier. So our take-home message is it's important to recognize imaging features that are associated with high-risk progression to proliferative diabetic retinopathy. So predominantly peripheral lesions, extensive OCT angiography, retinal non-perfusion. It's also important to recognize even structural OCT and OCT angiography features that are suggestive of a worse visual prognosis, and which structural features correspond to OCT angiography non-perfusion, such as interretinal atrophy or ripple retinal ischemic perivascular lesions, as well as OCT angiography evident macular ischemia.